My dear respected teachers, colleagues, and other members of BD Physicians, Assalamu alaikum. I am Dr. Nahida Akhtar, MS PhD resident, Department of Obstetrics and Gynecology, Bangabandhu Sheikh Mujib Medical University. At first, I want to express my gratitude to Dr. Ehsan sir and BD Physicians for giving me the opportunity to moderate today's scientific session. Today's scientific session topic is diabetes mellitus in pregnancy. It's a time-demanding topic. Diabetes mellitus affects both the health of the mother and baby. Chance of congenital abnormality is more in baby if diabetes mellitus remain untreated or uncontrolled in pregnancy. Chance of subsequent recurrence in subsequent pregnancy is more than 50%. So it's high time to be aware and to make people aware. So welcome to all of you in today's scientific session. Today, we have three legendary professors with us. As a chairperson, we have respected gynecologist who is a renowned gynecologist, who is a real gem and real diamond, Professor Dr. Kohinoor Begum Madam, past President, OGSB, Professor, Department of OBGYN, Popular Medical College Hospital, Dhaka. As a chairperson, we have renowned endocrinologist with us, who is the mentor of our mentors also, Professor Dr. Farooq Pathan sir. He is the director, Bardem Academy, and chief patron, Bangladesh Endocrine Society. As a speaker, we have a renowned gynecologist with us, who is a brilliant presenter, Professor Dr. Begum Nasrin Kiron ma'am, Chairman, Department of OBGYN, Treasurer, OGSB. We are very much delighted and blessed to have all of you in today's scientific session. Now, I'm requesting Professor Dr. Kohinoor Begum Madam to say a few words on opening remarks of today's scientific session. Please, ma'am.
আসসালামু আলাইকুম, তোমাকে অনেক ধন্যবাদ। আজকের টপিকটা চয়েস করার উদ্দেশ্য হলো শোনা যাচ্ছে না? না, শোনা যাচ্ছে ম্যাডাম, মিউট করাই আছে, শোনা যাচ্ছে?
শোনা যাচ্ছে।
আচ্ছা আচ্ছা, তো আমাদের এই টপিকটা নেওয়ার উদ্দেশ্য কি, যে এটা ওয়ান অফ দ্য কমনেস্ট মেডিকেল ডিসঅর্ডার ইন প্রেগনেন্সি। অ্যানিমিয়ার পরেই এটার রোল, এবং আমরা ডে টু ডে এটা ফেস করি, তারপরে এর কমপ্লিকেশন গুলি ফেস করি। আর এতই এটা পরিবর্তনশীল, এন্ডোক্রাইনোলজিস্টের মতামত একরকম, অবস্টিশিয়ানের মতামত একরকম, সবকিছু মিলেই এই টপিকটা চয়েস করার উদ্দেশ্য হলো সবাই যেন একটা কনসেন্সাসে আসতে পারি যে হাউ টু অ্যাপ্রোচ এ প্রেগনেন্সি উইথ ডায়াবেটিস মেলিটাস to prevent the complications and both the mother and the baby, and outcome, maternal outcome, fetal outcome ভালো হয় সেজন্য। সো সেজন্য চয়েস করেছে। তো আমি মনে করি যে বেগম নাসরিন খুব সুন্দর করে প্রেজেন্ট করবে, আমরা খুব উপকৃত হবে, এবং দর্শক যারা আছো তারাও যদি দরকার লাগে আপনারা কোশ্চেন করতে পারেন, আমরা ট্রাই করবো আমাদের বেস্ট টু গিভ ইউ অ্যান্সার। থ্যাংক ইউ। নাহিদ। নাহিদা,
নাহিদা তুমি শুনতে পাচ্ছ না? হ্যালো, ও মনে শুনতে পাচ্ছে না। নাহিদা তুমি মোবাইল থেকে ঢুকো, তোমার কথা শোনা যাচ্ছে না।
তুমি আপনার প্রেজেন্টেশন শুরু করে দেন ম্যাডাম, আপনার প্রেজেন্টেশন শুরু করে দেন ম্যাডাম।
আমি শুরু করে দিই ম্যাডাম?
হ্যাঁ,
আপনি শুরু করে দেন ম্যাডাম।
ওকে, থ্যাংক ইউ। Respected Chairperson Professor Kohinoor Madam, ex-President OGSB, renowned gynecologist, our beloved teacher, another Chairperson Professor Farooq Pathan sir, Director Bardem Academy, and Chief Patron Bangladesh Endocrine Society, Moderator Nahida, and learned audience. Assalamu alaikum and good evening. I am grateful to BD Physician, especially to Dr. Ehsan, to give me the opportunity to present in such a large platform. Today, the topic of my presentation is diabetes in pregnancy. Global burden. The prevalence of diabetes in pregnancy has been increasing in parallel with worldwide epidemic of obesity. More than 16% live births are affected by hyperglycemia in pregnancy, and among these 75 to 90% are GDM. it is reported by International Diabetic Federation. Now today's lecture will cover pathophysiology, classification, screening of GDM, risk factor of gestational diabetes mellitus, maternal fetal disease, management of GDM, and management of pre-gestational diabetes in pregnancy. Physiological changes of glucose metabolism in pregnancy. Pregnancy is a state of insulin resistance and relative glucose intolerance. This is due to placental production of anti-insulin hormone. Among these, most important is human placental lactogen, cortisol, glucagon. In pregnancy, fasting blood sugar level a bit decreased than non-pregnant women. Postprandial blood sugar level rises. Insulin production increased twofold in normal women. Insulin requirement increased in diabetic women and decreased renal threshold for glucose. As a result, there is glycosuria. You can see in this picture, there is hyperinsulinemia. Insulin production is also increased, but insulin cannot work. As a result, there is as a result of insulin resistance. Now, pathophysiology of gestational diabetes mellitus. In the metabolic goal of pregnancy are uninterrupted nutrition supply to the fetus. In early pregnancy, there is anabolic store or to meet the metabolic demand in the late pregnancy. In late pregnancy, the fuel is provided for the fetal growth and energy need. One of the important metabolic adaptation of pregnancy is glucose metabolism. During early gestation, insulin sensitivity increases and promoting uptake of glucose into adipose store in preparation for energy demand in the later pregnancy. In second and third trimester, human placental lactogen, placentally derived human growth factor, progesterone, cortisol, prolactin, and other hormone increases, which causes decreased insulin sensitivity in the peripheral tissue like adipocytes, skeletal muscle by interfering with the insulin receptor signaling. An environmental factor and genetic factor also influences the extent to which the mother can properly compensate for this increased insulin resistance. In 5 to 10% pregnant population, insulin resistance, impaired insulin secretion, and higher level of hepatic gluconeogenesis result in elevated glycemia, leading to development of GDM. We here in this picture, I've already said insulin resistance due to placental secretion of anti-insulin hormone, and hepatic. There is also hepatic glucose production by 25 to 30% to meet the fetal demand in late pregnancy, and pancreatic beta cell dysfunction. This may be due to genetic factor, may be autoimmune disorder, and or chronic insulin resistance. All these factors contribute to gestational diabetes mellitus. Now, classification. Diabetes in pregnancy falls into two categories. One is gestational diabetes mellitus and another is pre-gestational diabetes mellitus. Gestational diabetes mellitus, it is the any degree of glucose intolerance with onset or first recognized during present pregnancy. It does not exclude the possibility that unrecognized glucose intolerance that may have been present before the onset of the pregnancy. Now, if you can look at this picture, diabetes in pregnancy divided into two: pre-gestational diabetes and gestational diabetes. Again, gestational diabetes, pre-gestational diabetes, pre-existing diabetes is either insulin dependent or type 1 diabetes, or non-insulin dependent or type 2 diabetes. And gestational diabetes again divided into two: gestational diabetes or diabetes in pregnancy. I will describe it later. Now, diagnosis of DIP or DIP means diabetes in pregnancy or gestational diabetes mellitus. Gestational DIP diagnosed, it may be diagnosed before the start of pregnancy or diagnosed for the first time during pregnancy, but it need meet the WHO criteria for diabetes in non-pregnant state. May occur any time of pregnancy, including first trimester. Gestational diabetes mellitus, when the blood sugar level, we call it the gestational diabetes mellitus, when the blood sugar level fasting 5.1 to 6.9 and 2 hours after glucose 8.5 to 11. Even in pregnancy, not diagnosed before, if this level is more than 6.9, that is more than 7 and more than 11, then it is called DIP. Hyperglycemia diagnosed for the first time, it may be diagnosed for the first time during pregnancy or may occur anytime during pregnancy and usually occur after 24 weeks of gestation. Now, gestational diabetes mellitus, regarding prevalence, I've already told it. Now, screening of gestational diabetes, it is very important. What is screening? The purpose of the screening is to identify asymptomatic individual with high probability of having or developing a particular disease. There is many questions regarding the screening of gestational diabetes, whether it should be selective or universal, when the screening should be performed, how should it be done. But opinion differ about the optimum screening and diagnostic technique due to difference in the population risk, cost effectiveness, and lack of evidence to support large national screening program. Risk factor for diabetes. We all know that there are risk factor for diabetes. What are those? That is family history of diabetes, especially for relative, the GDM in previous pregnancy, BMI more than 23 kg per meter square, or significant weight gain during early childhood, between the pregnancy or in early pregnancy, age more than 35 years, and member of high risk population. Those are South Asian, African, Caribbean, and Middle Eastern country population. If these patients are also at risk of gestational diabetes, history of poor obstetric outcome, those are history of stillborn, neonatal death, history of macrosomia, history of congenital malformed baby. Maternal birth weight is also risk factor. If maternal birth weight is more than 4 kg or less than 2.7 kg, these mothers are especially at risk for developing GDM. Glycosuria in the first antenatal visit, PCO cases, and if the patient are taking glucocorticoids in present pregnancy, if there is fetal macrosomia, polyhydrosis, or PIs, these patients are at risk of gestational diabetes mellitus. Now, time of screening. When we'll do the screening? Regarding the time of screening, OGTT, most guideline recommended conducting the test between 24 to 28 weeks of gestation. However, WHO guideline recommends conducting OGTT anytime. FIGO guideline recommend at 24 to 28 weeks of gestation or any other time. Regarding high-risk pregnancy, for women who are at high risk for developing hyperglycemia in pregnancy, there is a consensus among the most of the guidelines that the screening for GDM should be conducted during the first trimester or first prenatal visit. How it should be done? In low-risk group of patients, WHO, IAD, PSG, FIGO, ADA recommend one-step strategy with 75 gram glucose, OGTT, with IAD, PSG criteria. NICE guideline and India guideline from India also use one-step strategy, but using different criteria. American College of Obstetrics and Gynecology, NIH, and Society of Obstetrics and Canada guideline recommend both one-step and two-step method with equal strength. WHO, what tell WHO? WHO recommend a strategy regarding the GDM screening, that is screening all pregnant women at booking should be screened. And if negative, then they are screened again at 24 to 28 weeks using OGTT. And those are high risk for GDM, again screened at 34 to 36 weeks of gestation. Now, ADA guideline. ADA recommend the use of either one or two-step approach. One-step approach involve performing OGTT with plasma glucose measurement when patient is fasting, and diagnosis made when any one of these met or exceed. What is that? Fasting if 5.1 or more, 1 hour after glucose 10 or more, and 2 hours after glucose 8.5 millimole per liter or more. What is two-step approach? Here, the 50 gram glucose is given to the patient irrespective of fasting status any time of the day. And if the level is more than 7.8, then they do 3-hour OGTT and they diagnose GDM if at least 2 of the following plasma level are at this level or exceeds this level. What is that? Fasting 5.3 millimole, 1 hour 10 millimole, 2 hour 8.6 millimole, and 3 hour 7.8 millimole per liter. What is DIPSI? DIPSI is another screening method. It is used in India. DIPSI means Diabetes in Pregnancy Study Group India. They recommend non-fasting oral glucose tolerance test with 75 of glucose with cutoff value more than 140 milligram per DL after 2 hours. Whether WHO recommend fasting OGTT after 75 gram glucose with cutoff, same cutoff, but this is non-fasting. DIPSI is non-fasting, and OGT WHO recommend fasting OGTT. How they diagnose the diabetes in pregnancy? If 2 hours after blood glucose is more than 200 milligram per DL, then it is diabetes mellitus. If more than 140 milligram per DL, then they call it GDM, and if less than more than 120, then DGGT, decrease gestational glucose tolerance. So there is many guidelines, WHO, ACOG, Canadian Diabetic Association, DIPSI. There is different method, different even level is different. I don't want to repeat this again. Why screening of GDM is important in pregnancy? To prevent maternal fetal complication associated with GDM. Women with gestational diabetes are ideal group for primary prevention of diabetes. Women with gestational diabetes mellitus are at risk of type 2 diabetes in future. So if we can do screening during the gestational period, they are screened out earlier and they take measure for the later in life. Their children are also at risk for the developing gestational diabetes in later in life and even subsequent generation. Maternal risk. What are the risks of GDM? In early patient, early pregnancy, the patient may develop spontaneous miscarriage. Later in pregnancy, preeclampsia, polyhydramnios, gestational hypertension, macrosomia, preterm birth, and even high risk for patient may develop pyelonephritis. During labor, preterm birth, traumatic delivery, all these are due to macrosomic baby, large big baby, and in case there is increased chance of intubated delivery, C-section, PPE, purple infection, maternal mortality and morbidity. Long-term complication. These patients may develop GDM in the subsequent pregnancy, and 35 to 40% risk of developing type 2 diabetes that are in pregnancy, risk of developing hypertension, obesity, and CVD. What is the fetal risk? Usually, there is no risk of congenital anomalies in the GDM group of patient, but there is risk of macrosomia, that is last for gestation, birth trauma, shoulder dystocia, IUD, respiratory distress syndrome, jaundice, birth asphyxia, neonatal hypoglycemia, and large for gestational children and those born to obese mother have 7% increased risk of developing IGT at the age of 7 to 11 years of age. Now, in this picture, you can see the maternal, if there is GDM, maternal hyperglycemia, this blood sugar passes to the placenta, to the fetus, fetal hyperglycemia, and this impaired glucose tolerance in the fetus, and this baby become larger. There is macrosomic baby, and after birth, this baby develop increased risk of developing hypoglycemia. Recent study showed that the children born to mother of diabetes during pregnancy have increased risk of eye problem. That is from early childhood to young adulthood. That is 39% risk of increased risk of developing myopia. That is high refractive error of the offspring. That is myopia, hypermetropia, or astigmatism. All among these GDM, some are high risk. Who are high risk? High risk for developing complication, then other GDM. These are called high risk GDM. Those are who are having a history of stillbirth, neonatal death, fetal macrosomia, concomitant obesity or hypertension. If in this pregnancy patient develop poly or oligohydramnios, in preeclampsia, macrosomia, and inadequate diabetic control with diet alone. This group are very risk for developing further complication, especially maybe this patient may develop stillbirth again in this pregnancy and other life-threatening complication. Now, management of gestational diabetes mellitus. Management issue, it covered the patient education, needs patient education, medical nutrition therapy, pharmacological therapy, glycemic monitoring, especially self monitoring of blood glucose, fetal monitoring, planning of delivery, and postpartum care. Primary management strategy of GDM include the dietary modification and exercise. If uncontrolled hyperglycemia with lifestyle changes, insulin should be the first line therapy. Medical nutritional therapy, therapeutic goal is to adequate nutrition, adequate weight gain, prevention of post-parental hyperglycemia, and prevention of ketosis. What is lifestyle and behavioral management? Lifestyle change is an essential component of management of GDM. Studies suggest that 70 to 85% patients with GDM can be managed with lifestyle modification alone. Medical nutritional therapy for GDM, it is an individualized nutritional plan developed between the pregnant person and the registered nutritionist. Food plan should provide adequate calorie intake to promote fetal and maternal health, achieve glycemic goal, and promote appropriate weight gain. What is MNT? Regarding MNT, the diet should contain minimum 170 gram carbohydrate, that is 35% of 2000 calorie diet, and minimum 71 gram protein and 28 gram fiber. These are, I have written this from the recent ADA guideline to 2024. Emphasis should be given on the mono unsaturated and polyunsaturated fat while limiting saturated fat and avoiding trans fat. Promoting higher quality nutrient-dense carbohydrate result in controlled fasting, postprandial glucose, cover lower free fatty acid, and improve insulin action, and may reduce the excess infant adiposity. A balanced micronutrient including nutrient-dense fruit, vegetable, legumes, whole grain, healthy fat, includes the nuts and seeds, fish are less likely to promote excessive weight gain. Processed food, fatty red meat, and sweetened food and beverages should be avoided. Regarding physical activity, improvement of glycemic control, reduction in the need to start insulin, and insulin dose requirement with exercise intervention. Different study shows that the type of exercise, it may be aerobic, it may be resistant exercise, or both. Direction of exercise study shows that it may be either 20 to 50 minutes per day, 2 to 7 days per week. Moderate type of exercise may help to control gestational diabetes mellitus. What is the glycemic goal of the GDM? Goal recommended by 5th International Workshop Conference of Gestational Diabetes Mellitus. The goal is fasting less than 5.3, 1 hour postprandial, less than 7.8 millimole per liter, and 2 hours postprandial less than 6.7 millimole per liter. Now, pharmacological therapy. Insulin is the first line agent recommended for treatment of GDM. If glycemic control is not achieved, after 2 to 3 weeks of lifestyle intervention, insulin treatment should be initiated. Regarding metformin and glyburide, they are not recommended first line treatment in GDM because they are known to cross placenta, and data on long-term safety for the offspring is of some concern. Now, I will show some study regarding the metformin. Metformin in gestational diabetes and offspring are followed up, and it is shown that the follow-up study of 5 to 10 years shows that offspring had higher BMI, weight to height ratio, waist circumference, and borderline increased fat mass. A meta-analysis demonstrated that metformin exposure resulted in smaller neonate with accelerated postnatal growth and resulting in higher BMI in childhood. In another study, we frequently use metformin in PCOS patient in irregular period, and we think that it will prevent the abortion. But in the recent study shows that metformin versus placebo from first trimester to delivery in PCOS patient, polycystic ovary syndrome, a randomized controlled multicentric study. Conclusion: metformin treatment from first trimester to delivery did not reduce the pregnancy complication in PCO. Another study with glyburide, pharmacokinetics and efficacy and safety of glyburide for treatment of the gestational diabetes mellitus, a meta-analysis systemic review. Glyburide was associated with a higher rate of neonatal hypoglycemia, macrosomia, and increased neonatal abdominal circumference than insulin and metformin. Long-term safety data for offspring exposed to glyburide are not available. So, আমরা কি করব? আমরা কি ওরাল হাইপোগ্লাইসেমিক এজেন্ট নিয়ে কিছুই করব না? এটাতে কোনো রোল নাই। তাহলে এখানে এটা বলা হচ্ছে GDM পেশেন্ট রিকোয়ারিং মেডিকেল থেরাপি বাট who may not be able to insulin safely and effectively during pregnancy due to any reason. It may be her he cannot use, cannot monitor. It may be it will be due to cost. In this patient you can give oral hypoglycemic drug. Oral hypoglycemic drug may be alternative for those individual after discussing the known risk factor, known risk. However, due to the potential for growth restriction and acidosis in placental insufficiency, metformin should not be used in pregnant women with hypertension, preeclampsia, and those at risk of FGR. এই গ্রুপ অফ পেশেন্টকে এটা দেওয়া যাবে না যাদের রিস্ক হাইপারটেনশন, প্রিক্লাম্সিয়া আছে এবং যাদের ভিটাল গ্রোথ রেস্ট্রিকশন আছে তাদেরকে দেওয়া যাবে না। তাছাড়া অন্যদেরকে কাউন্সিলিং করে রিস্ক গুলো বলে এটাকে দেওয়া যাবে। আচ্ছা, নাও ইনসুলিন রেজিমেন, আমরা ইনসুলিনটা কিভাবে দিব? ইনসুলিন তো বলছে যে ডিফারেন্ট ইনসুলিন রেজিমেন প্রপোজড ফর ট্রিটিং hyperglycemia, but multiple daily injection most efficient and most flexible. Insulin regimen should be chosen based on the blood glucose profile. If fasting blood sugar is higher, then basal insulin should be initiated, that is either long-acting or isopen insulin should be prescribed. Basal dose should be 0.2 unit per kg per day. If hyperglycemia following meal, then rapid acting insulin or regular insulin should be initiated before meal. Sometimes it is seen that both fasting and postprandial glycemia are elevated. Then you will give multiple daily injection, 3 bedtime insulin and 3 mealtime insulin and basal insulin at bedtime. This slide shows the arbitrary guide to start insulin doses according to the body weight of the period of gestation. You can see here that at weeks of gestation, daily dose at 1 to 13 weeks, 0.6 unit per kg body weight, and 40 to 26.8 and 27 to 37.9 into kg body weight, and 38 to 41 unit per kg body weight. But these may not fit for all pregnancy. Usually in pre-gestational diabetes mellitus, total insulin need is 2 times higher than the GDM. In morbid obese patient, initial insulin dose may need to increase 1.5 to 2 unit per kg to overcome the combined insulin resistance of pregnancy and obesity. Total daily dose of insulin should be divided into 2 in type 1, type 2 diabetes, the 50% basal insulin at bedtime and 50% divided into 3 meal time and given rapid or regular insulin before meal. Now, monitoring of the blood glucose. How will monitor the blood glucose level? Self-monitoring. Patient is counseled for self-monitoring and fasting and towards postprandial. Blood sugar should be checked 4 or more times a day to make sure that the level stay within the target range. After achieving the target level, patient lab monitoring also is advised. Objective is to maintain near euglycemic throughout the pregnancy. Sometimes we may need to administer steroid, and we know that steroid increase blood sugar level further. So following first dose of prophylactic administration of glucocorticoid, the dose of insulin adjustment is needed. It should be increased by 40% of their pre-corticosteroid insulin dose according to self-monitoring of blood glucose. This increased dose is required from the day 1 of steroid administration up to day 5. Thereafter, dose of insulin should be tapered by 6 to 7 days to pre-steroid administration doses. Now, some thing about the pre-existing diabetes mellitus in pregnancy. Here, pre-conception counseling is very, very important. It should be started from the puberty. All diabetic patients having reproductive potential should be counseled. Essential to achieve normal pregnancy outcome. Regarding if when the patient is uncontrolled diabetes, then contraceptive should be advised, and patient only when they become euglycemic, then patient is advised to take pregnancy. and counseling should be addressed to keep the hemoglobin A1C 6.5% or less to reduce the complications of pregnancy. Preconceptional counseling should include importance of glucose control during pregnancy, as inadequate glucose control increase the risk of complication, abortion, congenital anomaly, macrosomia, polyadministrative stillbirth, and a patient should be counseled about the importance of self-monitoring and importance of fetal surveillance during pregnancy. Women with pre-existing diabetes mellitus should be managed in a multidisciplinary clinic that include endocrinologist, fetal-maternal specialist or obstetrician, registered dietitian, nutritionist, and diabetic educator is recommended if the resource is available. If the resource is not available, when the single specialized center is not available, providing a interprofessional team approach through interprofessional team members at different centers may still be beneficial. All patients should be assessed before regarding the renal function, retinal examination, and liver function test and blood profile should be done before going to pregnancy, planning for pregnancy. Now, this is the outline how we can manage pregnancy with diabetes before pregnancy, preconception counseling, and once she become pregnant, then a dating scan, it can be done within the 10 weeks of gestation, optimization of glycemia, screening for congenital anomalies, screening for diabetic complication, non-diabetic comorbidity, and advice hypoglycemia prevention. In second trimester, we'll do congenital anomaly screening and fetal echo and surveillance for medical obstetric complication and assessment fetal growth. In third trimester, surveillance for medical obstetric complication, fetal growth, and surveillance should be started as early as 32 to 34 weeks. In between, patient is assessed by NST, ultrasound, biophysical profile, and modified biophysical profile. Now, screening for congenital anomaly, we know hemoglobin A1C is very important. This test is performed 4 to 6 weeks after conception. This reflects the level of blood glucose in preconceptional period. And if we think that is increased risk of congenital anomaly, we can do the other tests like maternal alpha fetoprotein, and if it is positive, then the genetic amniocentesis may be needed. Other tests, triple test, quadruple test, these are not always we do not do this test regularly, but if there is risk for complication, then we may need to do this test. Anomaly scan, NT scan, first trimester scan, we all know that it is done in 11 to 13 plus 60 weeks of pregnancy, and routine anomaly scan is done at 18 to 20 weeks of gestation, and fetal echocardiography is done 22 to 24 weeks of gestation. We know uncontrolled diabetes, there is risk of cardiac anomaly, so fetal echo should be done in this group of patient. What are the common anomalies of the infant, of diabetic mother? Central nervous system involving central nervous system, meningoencephaly, holoprosencephaly, spina bifida, heart and gate vessel, transposition of gate vessel, HDV, HD, coarctation of the aorta, skeletal and spinal an anomaly, that is caudal ligation syndrome, genitourinary, renal agenesis, ureteral duplication, and gastrointestinal, anal atresia. There is so many complications that may occur if the patient planned pregnancy in a unplanned way. If the diabetes is control in the periconceptional period. What is the glycemic goal in DIP? ADA recommend the target for pregnant women with type 1, type 2 diabetes as follows. Fasting should be within 3.9 to 5.3, 1 hour after postprandial, 6.1 to 7.8, 2 hours postprandial, 5.6 to 6.7 millimole per liter. Now, something about hemoglobin A1C. Observational study shows that increased risk of embryopathy, I've already mentioned, is directly proportional to the elevation of the hemoglobin A1C during the first 10 weeks of pregnancy. And in other observational study, it is shown that pre-existing diabetes and pregnancy showed an lowest rate of adverse fetal outcome with hemoglobin A1C less than 6 to 6.5 in early gestation. In second and third trimester, A1C less than 6% had lowest risk of large for gestational age infant and preterm delivery and preeclampsia. Taking all this all this into account, the goal of hemoglobin A1C is less than 6% is optimal if it can be achieved without significant hypoglycemia. But if there is risk of hypoglycemia and patient repeatedly develop hypoglycemia, in this case, the goal may be relaxed to 7% to prevent hypoglycemia. Now, control of hyperglycemia. Insulin should be used to manage type 1, type 2 diabetes in pregnancy. Multiple daily injection or insulin pump technology can be used. Blood glucose monitoring and frequent titration of insulin to match the changing requirement is needed. Type 1 diabetes in pregnancy. Women with pregnant women with type 1 diabetes have increased risk of hypoglycemia in first trimester. So, education for the women with diabetes and family members about the prevention, recognition, and treatment of hypoglycemia is important before, during, and after pregnancy. Pregnancy is a ketogenic state, and people with type 1 diabetes and to lesser extent type 2 diabetes are at risk of developing diabetic ketoacidosis. Pregnant women with type 1 diabetes should be advised to obtain ketone test strip and advised to receive education on the DKA prevention and detection. DKA carries a high risk of stillbirth. I have already said everything. First trimester, how will monitor pregnancy? First trimester, clinical examination, dating scan, nuchal translucence, NT scan, biochemical screening if needed. Second trimester, especially anomaly screening and fetal echo. Third trimester, clinical examination, fundal height, whether it correspond already large for gestational baby, abdominal guard, growth scan at 28, 30 to 36 weeks, color Doppler if needed. Is estimated fetal weight, AFI, and non-stress test. It should be started 32 weeks of gestation. Already told everything. Especially important who are high risk for GDM. Surveillance should be started at earlier, that is 32, 34 weeks, and weekly or twice weekly anesthesia is needed, and biophysical profile and ultrasonogram is needed frequently in this group of patients. Now, time and mode of delivery. Regarding gestational diabetes mellitus, this is taken from NICE guideline. As in ADA guideline, there is no recommendation regarding the time and mode of delivery. Gestational diabetes, no complication. Then we can wait up to 40 plus 6 weeks. That is 46 days of pregnancy. If patient has any maternal fetal complication, we have to deliver before this time, that is 46 days of pregnancy. In these cases, we have to consider elective birth, that is either induction or Caesar if needed. In the Western book, it is written that estimated fetal weight more than 4.5 kg needs cesarean section, but in our country, we consider 4 kg. If the estimated fetal weight is 4 kg, cesarean section, counseling for cesarean section is done. In type 1, type 2 diabetes, no complication. Even there is no complication, then termination should be done between 37 plus 0 to 38 plus 6 days pregnancy. If metabolic complication or maternal fetal complication, delivery should be done before 37 weeks of pregnancy. And in these cases, how will deliver? Either induction of labor, and if fail, then cesarean section, or directly you can do for cesarean if there is indication. Care during delivery, care of labor in delivery, admission CTG should be done. Patient should be monitored by the labor care guide. during labor, blood sugar should be kept between 4 to 7 millimole per liter, and continuous fetal monitoring is needed. If the patient is on insulin, then especially this thing should be IV glucocorticoids and insulin infusion should be considered for the women with type 1 diabetes from the onset of the established labor, because this patient in labor can develop, there is risk of developing hypoglycemia. Of course, this patient should be delivered in institution, presence of expert obstetrician and close fetal monitoring is needed. The second stage of labor managed by the controlled ARM. There in anticipate shoulder dystocia, assisted vaginal delivery may be needed. Neonatologist and 10% to resuscitate must be present. And third stage managed by the active management, third stage labor watch for traumatic or atonic postpartum hemorrhage. Close monitoring in the second stage, and in second stage it should be also monitored that whether there is fetal distress. If the elective cesarean section is done, it should be done early in the morning to prevent prolonged fasting, and in this time patient should maintain optimum hypoglycemic control. If there is delay and if unable to perform surgery immediately, start insulin drip, and if patient is poor control, in this case also insulin drip should be started. Immediate postpartum care of GDM on MNT. যেসব পেশেন্টরা মেডিকেল নিউট্রিশন থেরাপির উপরে আছে, সেখানে আমরা ইন মোস্ট অফ দ্য কেসে প্লাজমা গ্লুকোজ নর্মালাইজ ইমিডিয়েটলি আফটার ডেলিভারি, সো সিস প্লাজমা গ্লুকোজ মনিটরিং immediately after delivery, and regular postpartum care is enough. If the patient is on pharmacological therapy should be stopped immediately after delivery, and blood glucose monitoring should be done 4 times a day for 24 hours after birth. That is pre-parendial. এখানে আমরা post-parendial করব না, pre-parendial করব, that is before bed time আগে এটা করব. Target is less than 8 millimole per liter. If the target is fulfilled, that is if the blood glucose level is 4 to 8 millimole per liter, we will stop monitoring after 24 hours after birth. But if the blood glucose is less than 4, then we have to consider IV fluid for 12 hours. If the blood glucose level is more than 8 millimole per liter, then we have to continue blood glucose monitoring, and insulin may be needed. Rarely it is needed, but if the pre-parendial level is more than 8, we have to monitor further, and accordingly we have to treat this. ADA recommendation for post-parental follow-up of these women with gestational diabetes mellitus. Oral glucose OGTT is recommended at 6 to 12 weeks postpartum visit. GDM is associated increased risk, maternal risk of type 2 diabetes mellitus, so lifelong screening is needed. Even this time is blood glucose level is within normal range, we have to do OGTT every 1 to 3 years to detect whether this patient are developing type 2 diabetes or not. Breastfeeding. Regarding breastfeeding should be encouraged immediately after delivery in order to avoid neonatal hypoglycemia. We all know that these babies are at risk of developing hypoglycemia. Early breastfeeding should be advised. Breastfeeding may confer long-term metabolic benefit both to the mother and baby. It lowers the risk of type 2 diabetes and hypertension later in the in the life of the mother, lower the risk of developing baby diabetes in childhood, and help to lose weight between the pregnancy and prevent obesity, and control blood glucose level after the birth of the baby. Now, contraception for women with diabetes and challenge and solution. Yet in this study, it is seen that recent data highlight the safety of hormonal contraception in relation to women with diabetes without complication of cardiovascular and microvascular risk factor. Copper, IUCD, IUS are suitable for women with type 1, type 2 diabetes. Injectable contraceptive, medroxyprogesterone acetate, are not contraindicated for healthy diabetic women, but who are at risk, high risk, complicated. In this case, also they seek special advice. Contraceptive implants are suitable for women with diabetes. Natural and barrier method of contraception are not contraindicated. Male and female literature is another option. Emergency contraceptive pill and copper ICT is suitable for all women with diabetes to prevent unintended pregnancy. So we can see here that all options are open for them, uncomplicated diabetes. But if there is other comorbidities, then we have to take a special attention. Key points. Hyperglycemia affect both maternal, fetal and maternal outcome. So euglycemic status should be maintained throughout the pregnancy. 70 to 85% of people diagnosed with GDM can be managed with lifestyle modification. Insulin is the first line agent recommended for the treatment of GDM, type 1 and type 2 diabetes in pregnancy. And patients should be educated about the cell, blood, glucose monitoring, insulin therapy, risk of hypoglycemia, and how to minimize and treat hypoglycemia. Thank you.